Welcome back to the deep dive. We don't just skim the surface here. We take this huge pile of really high-yield medical info, and we try to find that one crucial detail.
Exactly, that pivot point. The thing that flips a diagnosis from maybe scary to totally benign, or maybe the other way around.
Yeah, or turn something you thought was just chronic into, well, a potential emergency.
And that's really our mission today. We want to give you that kind of cheat sheet that experienced clinicians, they build up over years.
Right.
Imagine you're faced with a patient, maybe with chest pain, or someone collapses, or they have this really complex mix of skin and joint problems. There's just so much data.
Overwhelming amount.
Totally. So our job today is to help you cut through that noise, lock onto that one, often really subtle thing. Could be a physical finding, maybe a detail in the history, maybe just how long something lasted that really drives the whole management plan.
So we're taking a fast but deep look through cardiology, vascular medicine, some musculoskeletal puzzles too.
Yeah, and we're not just interested in the vague stuff like my legs hurt or I feel a bit faint.
No, we want to know why. Why does the specific texture of a scar, or whether pain lasted hours versus, say, minutes? Why does that, or just being able to reproduce pain with a finger, tell you more sometimes than a really expensive scan?
It's all about specificity, isn't it? That's the
Yeah.
power here. We're decoding that clinical language, the pattern recognition, focusing on things you can actually see or hear or reproduce with your own hands.
Okay, let's dive right in. The big one, chest pain. Right. Chest pain. When someone gets that acute pain, the first thought, almost instinctively, is heart attack, right? Myocardial infarction.
Always. That's the fear.
But our sources are pretty clear that actually the most common reason people end up in the ER with chest pain is musculoskeletal.
Oh, absolutely. Overwhelmingly so.
And the main culprit? Costochondritis.
Yeah, costochondritis. It sounds complicated, but it's basically just inflammation where the ribs meet the breastbone. Those costochondral or sternochondral joints.
So it's a mechanical thing.
Totally mechanical. The cause is almost always some kind of, mechanical stress. Maybe you lifted something heavy awkwardly, or you had a really bad cough, like a violent sustained cough from being sick.
Or maybe overdid it working out.
Exactly.
Yeah.
Overdoing exercise. And this thing, it's super common, completely benign, but boy, can it mimic heart pain. The sharpness, the location, it feels serious.
So how do we tell this apart from something really dangerous, like, say, unstable angina? What's the key thing, the hinge factor?
The hinge factor is all in the physical exam. It's basic, almost the oldest trick in the book. Palpation.
Just pressing on it.
Just pressing on it. Costochondritis causes this sharp, localized pain right on the front of the chest, and the absolute key is that it's reproducible with palpation, right over those joints near the sternum.
So you gently but firmly press where the patient says it hurts.
And if that pressure makes the pain worse or even makes them flinch or jump, that's a huge sign pointing away from a deep cardiac problem.
Wow, that's a powerful shortcut.
It really is.
Yeah.
And if the pain also gets worse with movement or taking a deep breath or coughing,
Yeah.
and the patient's otherwise okay, younger, generally healthy, no fevers or drenching sweats,
Right, no systemic signs.
then you can be pretty confident this is just self-limiting inflammation.
And that leads to a really important point about management, about saving resources.
Crucial point. The main treatment is simple reassurance, telling the patient what it is, that it's not their heart, and basic pain relief.
Like ibuprofen.
Yeah, NSAIDs, nonsteroidal anti-inflammatory drugs like ibuprofen, or even just acetaminophen. If you've got those classic features, jumping to big tests like a CT scan, looking for a blood clot in the lung, a PE, or checking troponin levels for a heart attack.
It happens all the time.
It does. But it's usually not needed here. You've pretty much made the diagnosis clinically with your hands and the history.
Okay, so that covers the bone and cartilage mimics, but there's another organ in the chest that's a master mimic, sending pain signals that can fool anyone.
Esophagus.
GERD, right.
Yeah.
Gastroesophageal reflux disease.
Oh, GERD is a classic.
Hmm.
And it fools us because of how our nerves are wired. It's this idea called the convergence theory.
Convergence, okay.
Yeah, the sensory nerves, the visceral afferents, from both the heart and the esophagus, they travel back and meet up at similar levels in the spinal cord.
Ah, so the brain gets mixed signals?
Exactly. The brain kind of gets confused. So irritation or spasm in the esophagus can cause pain that feels like it's coming from the neck, the jaw, the back, the chest. It sounds just like cardiac pain sometimes.
So if the quality of the pain can be similar, squeezing, burning, pressure, what's the critical clue? The thing that saves time and points towards the GI tract instead?
It often comes down to duration and timing.
Okay.
This is about typical angina, heart pain, from poor blood flow. Usually lasts just a few minutes, right? Maybe 5, 10 minutes tops. Often brought on by exertion, gets better with rest or nitroglycerin.
Right. Short-lived.
But esophageal chest pain. It's often prolonged. It can go on for hours.
Hours, not minutes.
Hours. Yeah, that's a huge clue. If a patient says, yeah, I had this awful chest pressure last night, started around 8 p.m., didn't go away till midnight,
That duration immediately makes you think differently.
it really shifts your suspicion away from stable cardiac issues. Plus, esophageal pain often hits at rest. It can be positional, maybe worse lying down, or happen at night. And crucially, it often doesn't respond to nitroglycerin.
But it might respond to.
It might respond to an antacid. That's another clue.
So let's put it together. You have a patient maybe younger, say under 50. Not many cardiac risk factors. They get chest pain at rest, lasts for hours, initial ECG, maybe even a stress test. Looks normal.
In that scenario, your focus should really pivot towards the esophagus. It becomes highly likely.
And the next step isn't necessarily a cardiologist.
Probably not immediately.
Hmm.
The pragmatic thing, the high-yield first move in that low-risk situation, often it's just a therapeutic trial.
Yeah.
Give them some antacids or maybe a proton pump inhibitor, a PPI to block acid.
And see if it helps.
Yeah. See if the pain goes away. It avoids putting the patient through potentially unnecessary, invasive, and expensive cardiac workups. That duration hours versus minutes, that's free information that saves time, money, and a lot of anxiety.
Okay, let's switch gears to a cardiac condition that's maybe less common, but incredibly important not to miss. Uremic pericarditis. This is in patients with advanced kidney failure, right?
Right.
CKD.
That's right. Chronic kidney disease. Usually when their kidney function is really poor, the BUN level, blood urea nitrogen, is typically very high, often over 60 milli-GDL.
And you mentioned this is a major diagnostic trap. Why?
It's a trap because it breaks a cardinal rule we learn about pericarditis. Inflammation of the sac around the heart.
Right, we expect ECG changes.
Exactly. We're taught that acute pericarditis, like from a virus, gives you those classic widespread ST elevation and PR depression findings on the ECG. Beautiful textbook changes.
But not here.
But in uremic pericarditis, those classic ECG findings are very often absent, completely missing.
But why? If the sac is inflamed, why wouldn't the ECG show it?
Because the inflammation here isn't usually from an infection directly irritating the heart muscle underneath. It's caused by the buildup of uremic toxins, urea, and other waste products because the kidneys aren't filtering them out.
So the toxins irritate the sac?
Yes, the inflammation is often confined just to the pericardial sac itself. The myocardium, the actual heart muscle, is typically spared from that direct irritation. And since the ECG changes come from involving the muscle, well, if the muscle's okay electrically, the ECG can look deceptively normal.
Wow. So the ECG can actually mislead you here. You can't rely on it.
You absolutely cannot rely on it to rule it out. You have to rely almost entirely on the clinical picture, the history, and a really careful physical exam.
So what are the key clues then if the ECG is out?
You need the context. You have a patient with known severe kidney disease. They come in feeling off, severe fatigue, nausea maybe, and they have sharp chest pain. That's typically pleuritic.
Meaning it hurts more to breathe in.
Yes, dramatically worse with a deep breath. And sometimes they feel a bit better leaning forward. But the absolute gold standard finding on exam, though it can be tricky to catch, it comes and goes.
What is it?
It's hearing a pericardial friction rub with your stethoscope, that three-component scratchy sound.
Okay. And the management is also critically different from typical viral pericarditis.
Totally different. And this is a life-saving distinction. For viral pericarditis, you might use NSAIDs, maybe colchicine.
Right.
But in uremic pericarditis, those drugs are often pretty ineffective because they don't treat the underlying cause. And NSAIDs might even be harmful given the poor kidney function.
So what is the treatment?
The only definitive life-saving treatment is hemodialysis. Urgent dialysis. You have to get those uremic toxins out of the blood. That's what's causing the inflammation.
So you treat the kidney failure to fix the heart problem.
Precisely. You have to address the root cause, the uremia, not just the symptom of chest pain. Knowing this difference is absolutely critical.
Okay, that was intense covering those acute crises. Let's maybe shift focus now to more chronic systemic problems. Things where maybe the body's basic building blocks, the structure itself, is somehow flawed.
Yeah, where we're looking for clues that build up over time, often visible in the skin, the joints, things you can see.
Let's start with a really distinctive one. Ehlers-Danlos syndrome, EDS.
EDS. It's really fascinating. It's not just one condition. It's actually a group of genetic disorders. And the root problem is defective collagen.
Collagen, the body's scaffolding protein.
Exactly. It gives strength and elasticity to pretty much everything: skin, bones, tendons, blood vessels. Common genes involved are things like COL5A1, ZO5A2. If your building materials are faulty from the start, well, the whole structure becomes fragile.
What are the absolute must-know features, the clinical triad we should look for if we suspect EDS?
Right, the triad, that's the memory hook. Number one, joint hypermobility. Really flexible joints, sometimes leading to recurrent dislocations. Shoulders pop out, knees give way, seemingly without much trauma.
Okay, hypermobility, what's two?
Number two, skin hyperextensibility. The skin is unusually stretchy. You can often pull it out maybe 4 centimeters or even more. It just snaps right back.
Wow. And number three?
Number three, tissue fragility. This shows up as really easy bruising, sometimes large bruises from minor bumps, and notoriously poor wound healing. Cuts take forever to heal.
And that poor healing leads to a very specific visual clue, doesn't it? The scars.
Absolutely, this is classic. When the skin does eventually heal after a cut or injury, the poor collagen means the scars are often very thin, wide, crinkly. They're described as atrophic, cigarette paper-like scars.
Cigarette paper scars.
Yeah. If you see a younger person, maybe with a history of joints popping out, easy bruising, and they show you these thin, papery scars on their knees or elbows or shins, EDS should jump right to the top of your list.
Are there other related signs?
Definitely. Because collagen is everywhere, you might also see things like hernias, uterine prolapse in women, sometimes mitral valve prolapse on an echo.
Now, this sometimes gets confused with Marfan syndrome, all right? Another connective tissue disorder. Patients can be tall, have loose joints. How do we tell them apart? Because the implications are different.
That distinction is vital. Marfan syndrome carries that really serious risk of aortic root dilation, the main artery stretching out, which can lead to a sudden fatal dissection. So they need close heart monitoring.
Okay.
Marfan patients are typically tall, long limbs, maybe those long spider-like fingers, arachnodactyly, but crucially, they generally do not have that profound skin fragility or those classic cigarette paper scars you see in EDS.
So skin signs point more to EDS.
Generally, yes. While classic EDS patients have the skin and joint tissues, they usually don't have the severe aortic root problems seen in Marfan. If there's any doubt, getting an echocardiogram to look at the aorta is key to assess that risk.
Okay, good distinction. Let's pivot now from genetics to physics, really. Gravity and fluid dynamics. Chronic venous disease, specifically chronic venous insufficiency, CVI. CVI, super common. And it's all about the veins in the legs, usually not doing their job properly. It's a consequence of incompetent venous valves.
The valves that are supposed to stop blood flowing backwards.
Exactly. Veins are low-pressure pipes. They need these little one-way valves to help push blood back up to the heart against gravity. When those valves fail, blood starts to pool in the lower legs.
And that pooling causes pressure.
Yes, it creates chronic venous hypertension, basically high pressure in those leg veins. That high pressure forces fluid out of the tiny blood vessels, the capillaries, into the surrounding tissues. And that's what causes the swelling, the edema.
What's the most important clinical clue for CVI? Thing that really points you towards it? You mentioned timing earlier.
Yes, the timing is absolutely key. High yield. If someone comes in saying their legs are swollen, feel heavy, uncomfortable, you have to ask about the pattern through the day.
And what's the classic pattern?
The symptoms are characteristically worse at the end of the day. After they've been standing or sitting for hours, gravity has made the pooling worse.
Makes sense. And just as importantly, the symptoms get better with leg elevation. Putting your feet up helps drain the pooled blood, or by walking around.
Walking helps. Why is that?
Because walking activates the calf muscles. The calf muscle pump is powerful. It squeezes the deep veins and helps push that trapped blood back up towards the heart.
Okay, so worse at the end of the day, better with elevation or walking. That pattern is key to differentiate it from swelling caused by other things, like heart failure.
Absolutely. Heart failure edema is usually more constant, often involves shortness of breath, maybe lung crackles, you might see neck vein distension. It's a systemic volume overload, not just localized pooling relieved instantly by putting your feet up.
And this leads to a really important management point you mentioned about diuretics, water pills.
Yes. Critical pearl, because CVI is fundamentally a pressure and flow problem in the leg veins, not a problem of having too much total body fluid. Diuretics are generally ineffective and inappropriate.
Wait, that seems counterintuitive. The legs are swollen with fluid. Why wouldn't a diuretic help get rid of it?
It's a really common misconception. Diuretics work by pulling fluid out of the whole bloodstream, trying to lower the total volume. But in CVI, the issue isn't too much total volume. It's that the volume is trapped locally in the legs due to high pressure from faulty valves,
So taking a diuretic just dehydrates the rest of the body.
pretty much. It can make the patient dehydrated without actually fixing the leg swelling caused by the venous backup. It doesn't fix the valve problem or the pressure.
So what is the right first-line treatment then?
It has to be mechanical. Things that directly address the pooling and pressure. Frequent leg elevation throughout the day, exercise, especially walking, to use that calf pump, and graduated compression stockings.
The stockings that squeeze the legs.
Yes, they provide external pressure to help prevent the pooling and support the veins. That's the mainstay.
Okay. Now, if that venous hypertension goes on for years unchecked, it starts to damage the skin, right? Leading to stasis dermatitis.
Exactly. Stasis dermatitis is the visible evidence of that chronic high pressure. What happens is red blood cells get forced out of the capillaries under that pressure.
Okay.
When those red cells break down in the tissue, they leave behind iron deposits, specifically hemosiderin. And that hemosiderin staining is what causes that characteristic reddish-brown kind of brawny pigmentation, usually around the ankles and lower legs. It looks like a permanent bruise.
And the skin itself changes too.
Yes. Over time, the skin often gets itchy, scaly, and the chronic inflammation can lead to fibrosis. The skin and the fatty tissue underneath become hard, thickened, almost woody feeling, sometimes called lipodermatosclerosis.
Woody induration. Got it. Now, when you see that classic stasis dermatitis look, what's a crucial check you absolutely have to do?
Non-negotiable.
Right.
Check the pulses in the feet, the dorsalis pedis on top, the posterior tibial behind the ankle. You need to confirm that the pulses are present and easily palpable. And feel the skin temperature should be warm.
Why is that so important? What are you ruling out?
You're ruling out significant arterial insufficiency, peripheral artery disease, where the problem isn't blood getting out of the legs, it's blood not getting in properly because the arteries are blocked.
Ah, completely different problem.
Totally different. If the pulses were weak or absent, if the skin was cool or pale, maybe painful, you'd immediately suspect arterial disease. That needs a totally different workup, like checking an ankle brachial index, ABI.
Yeah.
And compression stockings, the mainstay for CVI, could actually be dangerous, could worsen arterial ischemia.
Good point. Okay, one more condition in this venous category. Post-thrombotic syndrome, PTS. This happens after something else, right?
Yes, PTS is a chronic condition. It develops usually within about 2 years after someone has had an acute deep vein thrombosis, a DVT, a blood clot, and deep leg vein.
What happens?
The DVT itself, the clot, damages the delicate valves inside that vein.
Yeah.
Even after the clot dissolves or is treated, those valves might be permanently scarred and incompetent.
So they end up with chronic venous insufficiency in that leg.
Exactly. They're left with the symptoms of CVI pain, swelling, heaviness, fatigue, but typically just in the one leg that had the DVT.
Okay, so the diagnostic challenge here must be the patient comes in with a painful, swollen leg. It looks just like they might have another DVT, a new one.
Precisely. That's the challenge. Do they have chronic damage, PTS, or do they have a dangerous new clot that needs anticoagulation again?
How do you tell the difference?
You get the Doppler ultrasound, the venous duplex scan. In post-thrombotic syndrome, the patient has the symptoms, the unilateral pain and swelling, but the Doppler ultrasound is negative. It shows no acute clot.
So the negative scan confirms it's the chronic aftermath, the PTS.
Yes, it tells you the symptoms are from the old damage, not a new emergency. And therefore, the treatment is focused on managing those chronic CVI symptoms, so exercise, compression stockings, not necessarily restarting long-term anticoagulation unless, of course, a new DVT is actually found.
All right, let's move into another really common and often frightening reason people seek medical help. Passing out. Syncope, or transient loss of consciousness.
Yeah, syncope. And again, like with chest pain, the duration of the event, the context around it, often tells you much more than complex tests right off the bat.
Let's start with the most common type, the simple faint. Vasovagal syncope.
Vasovagal, or neurocardiogenic syncope, it's basically a benign reflex. The nervous system kind of overreacts to a trigger, causing a sudden drop in heart rate and blood pressure.
And the brain doesn't get enough oxygen for a moment.
Exactly. Momentary lack of perfusion, and down you go. But it has really specific characteristics, usually 3 key components we listen for in the history.
Okay, walk us through those.
First, the actual loss of consciousness is typically very brief, usually just a minute or 2, maybe even less. Then you wake up.
Okay, brief duration.
Second, there's almost always a distinct prodrome. That's the warning phase just before passing out. The patient feels specific things coming on, maybe getting lightheaded, feeling intensely warm or hot, breaking out in a sweat, feeling
So they
nauseous.
know it's coming.
Often, yes. They feel unwell first. And third, there's usually a clear trigger. Something sets it off. Could be emotional stress, seeing blood or a needle, experiencing severe pain, or even just standing for a long time, especially in a hot place.
Okay, brief LOC, clear prodrome, identifiable trigger. If the story fits that perfectly and the basic exam and ECG are normal, what's the plan?
Reassurance is key. Explain what happened, that it's a common reflex, usually not dangerous, and advise them to try and avoid their known triggers if possible, or learn maneuvers like lying down when they feel the prodrome.
Do they need a big workup after one typical faint?
Generally, no. If it's a classic vasovagal faint in an otherwise healthy, low-risk person, you usually don't need extensive, expensive testing like Holter monitors, tilt table tests, or brain scans after just one episode. The history is often diagnostic. You need the confidence to trust that classic story.
Okay, next type. Orthostatic syncope. You mentioned this is often a volume problem, maybe in athletes.
Yeah, orthostatic syncope is fainting related to standing up. It's often due to hypovolemia, just not having enough fluid volume in the bloodstream. Or sometimes it's due to problems with the autonomic nervous system, the system that regulates blood pressure automatically.
How does that cause fainting?
When you stand up, gravity pulls blood down into your legs. Normally, your body instantly compensates, blood vessels constrict, heart rate might increase slightly to keep blood pressure up and blood flowing to the brain. The baroreceptors manage this.
Right?
But if you're dehydrated or your autonomic system isn't working right, that compensation fails, blood pressure drops too much when you stand, the brain doesn't get enough flow, and you feel lightheaded or pass out.
And athletes trying to cut weight quickly might be prone.
Yes, athletes using diuretics or severely restricting fluids to make weight for a competition are a classic example of hypovolemia leading to orthostatic intolerance.
What's the definitive diagnostic test here? It's bedside, right?
It is. The orthostatic vital signs check. It's crucial. You measure their blood pressure and heart rate while they're lying flat, then have them stand up and measure again immediately and then again after 3 minutes of standing.
What are you looking for? What drop confirms it?
You're looking for a significant drop within those 3 minutes. Specifically, a fall in systolic blood pressure, SBP, of 20 millimeter Hg or more, or R, a fall in diastolic blood pressure, DBP, of 10 millimeter Hg or more.
20 systolic or 10 diastolic within 3 minutes.
Correct. If you see that drop, especially if labs show signs of dehydration like hemoconcentration, that points strongly to orthostatic syncope.
Okay. Now for the really tricky one, psychogenic pseudosyncope, PPS. This sounds complex. It looks like fainting, but isn't.
Exactly. PPS is considered a functional disorder. The person appears to lose consciousness, but there isn't an actual drop in blood flow to the brain causing it. It mimics syncope, but the physiology is different.
This must be challenging to diagnose. You have to rule out serious stuff first.
Absolutely. You always have to exclude dangerous cardiac causes like arrhythmias or neurological causes like seizures before considering PPS. But PPS does have some features that can help differentiate it, though it takes careful observation. The biggest clue is often the duration.
Duration again. How long do these episodes last?
Well, think about true vasovagal or cardiac syncope. It's over in seconds, maybe a minute or two. PPS episodes, however, are often prolonged. They can last many minutes, sometimes even hours.
Hours of appearing unconscious.
Yes. If someone seems out for 30 minutes, it's highly unlikely to be a simple faint or a typical cardiac event. Also, patients with PPS may actually retain some degree of awareness during the event, even if they appear unresponsive.
Are there physical signs?
Their eyes are often kept tightly closed during the episode, which is unusual in true syncope, where eyes might be open or fluttering. And critically, if you check their vital signs during the apparent collapse, the heart rate, blood pressure, oxygen saturation, they typically remain completely normal. The physical exam is normal.
And what about afterwards, when the episode ends?
That's another big clue. Unlike true syncope, where there might be some brief confusion or a seizure which has a definite posictal state of grogginess, patients with PPS can often return to normal conversation or activity almost immediately after the event stops.
Recognizing these features must save a lot of unnecessary, potentially invasive tests.
It really does. It helps avoid aggressive workups for what is ultimately a functional condition, not an immediately life-threatening organic one. But it requires very careful assessment and ruling out the dangerous mimics first. It's a diagnosis of exclusion often.
Definitely sounds like it requires clinical skill and patience. Okay, shifting from fainting itself to a related physical sign. Pulsus paradoxus.
Ah, pulsus paradoxus.
Defined as that exaggerated drop in systolic blood pressure more than 10 millimeter Hg during normal, quiet breathing in. We're taught to immediately think cardiac tamponade, fluid squeezing the heart.
That is the classic life-threatening association, absolutely. Fluid in the pericardial sac restricting the heart's ability to fill.
But the sources highlight a surprising non-cardiac cause, one that's actually quite common in emergency settings or ICUs.
Yes, this is a great clinical pearl. Pulsus paradoxus can also be caused by severe asthma exacerbations or severe COPD exacerbations.
Really? Lung disease causing that specific blood pressure finding? How does that work? The mechanism must be different.
It is different, but it's still about physical restriction of the heart. During a really severe asthma attack or COPD flare-up, the patient is working incredibly hard to breathe.
Hmm.
They're generating huge negative pressure inside their chest to try and suck air into obstructed airways.
Okay, working hard to breathe.
And their lungs become hyperinflated, trapping a lot of air. During inspiration, when they make that big effort, the overinflated lungs actually swell up so much within the chest cavity that they physically compress the heart.
So the lungs are literally squeezing the heart from the outside.
In effect, yes, especially the right side of the heart initially, but this increased intrathoracic pressure and the lung expansion impede the filling of the left ventricle as well. Less blood gets into the left ventricle during that inspiratory effort.
And less blood in means less blood pumped out, causing the systolic pressure to drop during inspiration.
Precisely. Less preload leads to a lower stroke volume, causing that significant drop in systolic pressure during inspiration, mimicking the hemodynamics of tamponade.
That's fascinating. So if you find pulsus paradoxus in a patient struggling to breathe with asthma or COPD.
It's a sign of extremely severe airway obstruction and respiratory effort. It tells you their condition is critical and they need aggressive respiratory support immediately. It reflects the severity of the lung problem, not necessarily a primary heart problem in that context. Vital connection to remember.
Okay, let's wrap the section by looking at how we assess risk before surgery. Preoperative risk assessment for non-cardiac surgery. The goal is basically to figure out if the patient's heart can handle the stress of the operation, right?
Exactly. Can their cardiovascular system tolerate the demands of anesthesia and the surgical procedure without having a major cardiac complication like a heart attack?
How do we estimate that risk?
We often use scoring systems. A common one is the Revised Cardiac Risk Index, the RCRI. It's based on 5 key risk factors that are usually easy to determine from the patient's history.
What are those 5 factors?
They are 1, a history of ischemic heart disease, like a previous heart attack or angina. 2, a history of congestive heart failure, CHF. 3, a history of stroke or TIA, cerebrovascular accident, transient ischemic attack. 4, having diabetes mellitus that requires insulin treatment. And 5, having significant kidney disease, specifically a creatinine level over 2 milli-GDL.
Okay, 5 factors. How do we use them?
You basically count how many the patient has. 0 or 1 factor generally means low risk. 2 factors is intermediate risk. 3 or more is high risk.
But there's a shortcut, right? Especially for lower risk patients. Something about how active they are.
Yes, the functional capacity assessment. This uses the concept of MET's metabolic equivalence of task. It's a simple yet powerful, non-invasive way to gauge their cardiac reserve.
MET-Ts. What's the magic number?
The key threshold is 4 METs. If a patient can comfortably perform activities that require 4 METs of exertion or more, it strongly suggests they have enough cardiac reserve to handle the stress of most typical non-cardiac surgeries.
What does 4 METs look like in real life? Give us some examples.
It's very practical stuff. 4 METs is equivalent to things like climbing 1 flight of stairs without needing to stop because of shortness of breath or chest pain, walking on level ground at a brisk pace around 4 miles per hour, doing heavy housework or fairly strenuous gardening, like digging or raking continuously, or maybe carrying a bag of groceries up a flight of stairs.
So things many people do routinely.
Exactly. If they can report doing these kinds of activities without significant symptoms, their heart is likely quite resilient.
So what's the bottom line rule then? If a patient has low RCRI risks, 0 or 1 factor, and they report good functional capacity, say, they can easily climb stairs, which is about 4 METs, do they need more heart tests before surgery?
Generally, no. That's the key takeaway. Low RCRI risk plus good functional capacity, 4 METs, means you can usually proceed to surgery without further cardiac testing, like stress tests.
Their daily activity level is basically their stress test.
In a way, yes. It's a very reliable indicator of their reserve. You'd only really consider doing formal stress testing if the patient had poor or unknown functional capacity, or maybe intermediate risk, and if the results of that test would actually change your plan, like would make you cancel the surgery, or perhaps optimize their medications more aggressively beforehand. If it won't change management, don't do the test. Trust the history when it's reliable.
All right, we're heading into the home stretch. We've saved a couple of more complex diagnostic puzzles for this last section, plus a really vital safety check from critical care.
Sounds good.
Let's start with the type of heart failure that can be really deceptive. Cardiac amyloidosis. It causes a restrictive cardiomyopathy.
Ah, yes, amyloidosis. It's insidious, this one. It's caused by abnormal protein fibrils, amyloid fibrils, infiltrating the heart muscle itself.
So the heart muscle gets filled with this stuff.
Basically, yes. And this infiltration makes the heart walls incredibly thick and stiff. This leads to what we call a restrictive cardiomyopathy. The main problem isn't pumping strength initially. It's that the stiff heart muscle can't relax properly to fill with blood during diastole.
So filling is the problem, not squeezing.
Exactly. And this is key, because the squeezing function, the systolic function measured as LVEF, left ventricular ejection fraction, is often normal or near normal, especially early on.
So it looks like heart failure with preserved ejection fraction, HFpEF.
Precisely. You get this picture of HFpEF, but the underlying cause is this specific infiltrative disease, amyloidosis, which has very different implications in treatments compared to, say, HFpEF caused by hypertension.
So we have this paradox. A really thick, muscular-looking left ventricle on an echocardiogram, but the patient has heart failure symptoms because the ventricle is too stiff to fill. What clues point specifically towards amyloidosis, separating it from more common causes of thickened hearts?
You have to look beyond the heart. Think systemically. Amyloidosis, especially the AL type, light chain amyloidosis, often affects multiple organs. So the pattern to look for is that concentric LV thickening on the echo, often with enlargement of both atria too.
Thick walls, big atria.
Plus evidence of involvement elsewhere. A huge clue is proteinuria, significant protein spilling into the urine, showing the kidneys are involved. Or other systemic signs might be present, like unexplained fatigue, maybe early satiety or bloating because the GI tract is infiltrated, easy bruising, sometimes an enlarged tongue, macroglossia.
And wasn't there a paradoxical ECG finding you mentioned earlier related to the thickness?
Yes, this is another classic hallmark, counterintuitive but really suggestive. Even though the heart muscle walls are physically very thick on the echo, the ECG often shows low voltage QRS complexes.
Thick heart, low voltage. Usually thick hearts give high voltage.
Exactly. That discrepancy happens because the amyloid fibrils themselves disrupt the normal electrical conduction through the heart muscle. So you get physical thickness but poor electrical signal amplitude. That combination, thick walls on echo, low voltage on ECG, is almost pathognomonic for cardiac amyloidosis.
Wow. So that pattern, thick heart, preserved squeeze function, but signs of failure, low voltage ECG, plus maybe kidney or GI signs, that should scream amyloid.
It absolutely should. That's the moment to stop thinking about standard HFpEF and start the specific workup for amyloid, which might involve advanced cardiac imaging like MRI, nuclear scans, or ultimately tissue biopsy.
And getting the diagnosis right is critical because the treatment is totally different.
Profoundly different. For AL amyloidosis, treatment might involve chemotherapy or even stem cell transplant aimed at the underlying plasma cell disorder producing the light chains. Nothing like standard heart failure therapy. So recognizing those systemic clues in ECG paradoxes is vital for getting the patient on the right, potentially life-saving path quickly.
Okay, really important distinction. Finally, let's end with a critical safety check. Something absolutely fundamental in hospital care, especially critical care. Managing central venous catheters, CVCs.
Ah, central lines, yes. Crucial safety point here.
These are the large IV lines put into big veins, like the subclavian under the collarbone or the jugular in the neck, ending near the heart. What's the absolute non-negotiable rule after placing one?
The rule is ironclad, 0 exceptions. You must never, ever use a newly placed CVC for infusion until you have definitively confirmed its correct tip placement.
Never use it before confirmation. Why is that so critical? What can go wrong?
Placing a central line is an invasive procedure, and complications can happen even with experienced operators. The biggest danger is malposition. The tip could end up in the wrong vessel, maybe pointing against the vein wall, or worse, it could inadvertently puncture the vessel or even migrate into the space around the heart, the pericardial sac, or the chest cavity, the pleural space.
And if you infuse fluid into one of those wrong spots,
it can be catastrophic. Infusing fluid or medication into the pleural space, causes a hydrothorax. Infusing into the pericardium can cause rapid cardiac tamponade, where the fluid compresses the heart and stops it from beating a soup. Effectively, that's a code situation. Even infusion against a vein wall can lead to perforation and extravasation.
So, how do we confirm the placement safely before using the line? What's the mandatory check?
The standard mandatory safety check is getting a chest x-ray, a portable chest x-ray taken immediately after the line is inserted.
What are you looking for on the x-ray?
Two main things. First, you confirm the catheter tip position. Ideally, it should be in the lower part of the superior vena cava, SVC, just above the junction with the right atrium. Not in the atrium itself, not in a peripheral vein, not coiled somewhere strange.
And the second thing?
Second, the X-ray is essential to rule out immediate procedural complications, most importantly in iatrogenic pneumothorax, a collapsed lung caused by accidentally puncturing the pleura during insertion, especially common with the subclavian approach.
So, no flushing the line, no hooking up fluids, no medications through it until that x-ray is done, reviewed, and confirms correct placement, and no pneumothorax.
Absolutely correct. Flushing or infusing anything before that confirmation is simply unsafe practice. It violates a fundamental patient safety rule. That simple chest x-ray is a critical step that prevents potentially lethal complications. It must be done. Hashtag tag outro summary. Final thought. We've really covered a lot of ground today, some complex stuff, but I think the main theme, the core lesson that keeps coming up is actually pretty simple.
Yeah, it seems like in so many of these high-stakes areas, the most powerful insight, the thing that really guides you, often comes from a simple, low-tech clinical clue.
Exactly. Think about it. Ruling out a heart attack, diagnosing benign costochondritis. It comes down to just pressing on the chest wall, right? Palpation.
Or telling the difference between hours of GERD pain and minutes of cardiac pain, just asking about duration.
Or spotting a serious genetic condition like EDS by noticing the specific cigarette paper texture of an old scar, things you can see and touch.
And avoiding tons of unnecessary tests before surgery, just by asking someone if they can climb a flight of stairs without getting winded. Their functional capacity.
But that functional capacity point, the METs,
Yeah.
it's such a practical measure of resilience.
Which brings us perfectly to our final provocative thought for you, our listeners. We talked about how being able to do activities requiring 4 métis or more is a key diagnostic sign. It shows enough cardiac reserve for many stresses, like surgery.
So think about yourself. The next time you're, say, carrying heavy groceries up the stairs or maybe doing some vigorous gardening, remember what you're doing. You're essentially performing your own personal stress test. You're quantifying your cardiac reserve in real time.
Is that functional capacity just about your fitness level? Or is it, as we've discussed today, actually a critical, maybe even life-saving clinical clue that says a lot about your body's underlying resilience? Something to think about.
Definitely something I'm all over. We hope these clinical pearls we dove into today really stick with you.
Thanks for joining us on the Deep Dive.
Until next time.